Welcome to another episode from the Veterinary Medicine Digest. Hello, and welcome back to the Veterinary Medicine Digest. Today, we are diving deep into one of the most intricate and challenging areas of small animal medicine, the delicate bidirectional relationship between the heart and the kidneys, known formally as canine cardiorenal syndrome or cardiovascular renal axis disorders. For decades, veterinarians have understood that disease in one of these vital organ systems often affects the other, but recent years have brought an increased ability to identify and understand the intricate, pathophysiological characteristics of this cardiovascular renal axis. Our discussion today will explore this profound organ crosstalk, covering everything from the standard classifications used by experts to the newest groundbreaking research involving advanced diagnostics and novel therapeutic agents designed specifically for this complicated syndrome. The goal of this exploration is not just to summarize, but to enhance our understanding, offering insights that illuminate the challenges and opportunities in managing our canine patients who suffer from this potentially devastating condition. The very definition of cardiorenal syndrome includes a variety of acute or chronic conditions where the primary failing organ might be the heart, the kidney, or both simultaneously, often due to an independent systemic condition. The core understanding is how the dysfunction of one organ system directly affects the injury or function of the other. In the veterinary world, a consensus group proposed a slightly broader term, cardiovascular renal axis disorders, defined as disease-induced, toxin-induced, or drug-induced structural or functional damage to the kidney or to the cardiovascular system, leading to disruption of the normal interactions between these systems, ultimately resulting in the ongoing detriment of one or both organs. To approach this complexity systematically, the condition has been categorized into various types, conceptually similar to the 5 subtypes suggested in human medicine. In veterinary medicine, the consensus group suggested an equivalent 5 subtypes within the cardiovascular renal axis disorders classification. These categories describe the primary insult, the sequence of events, and the chronicity of the underlying process. The system is fundamentally broken down into 3 major classes based on which system is primarily affected: cardiovascular disease, kidney disease, or an independent systemic condition affecting both. Let us begin with the heart-first scenarios, often classified as types 1 and 2 of the cardiorenal syndrome, or cardiovascular renal axis disorder heart. Type 1 cardiorenal syndrome, also known as acute cardiorenal syndrome or cardiovascular renal axis disorder heart unstable disease, is characterized by a rapid impairment of cardiac function that quickly leads to acute kidney injury or dysfunction. The inciting event here is often acute heart failure or an acute worsening of chronic heart failure. This rapid insult affects the kidneys through multiple and complex mechanisms. First, there is reduced renal perfusion, a direct consequence of decreased left systolic function. Secondly, the body attempts to compensate, triggering the activation of neuroendocrine and sympathetic systems, which can further compound the issue. Finally, passive congestion of the kidney plays a critical role. This congested state can decrease the kidney's responsiveness to diuretics, potentially leading to the excessive use of these drugs and subsequently, further kidney injury. It is crucial to note that early recognition of acute kidney injury remains difficult due to the historical reliance on biomarkers that only become elevated once the injury process is already well established, often when it is too late to protect the kidneys or prevent progressive damage. Moving to the chronic forms, type 2 cardiorenal syndrome, or chronic cardiorenal syndrome, corresponds to the cardiovascular renal axis disorder heart stable disease. This subtype involves chronic cardiovascular disease causing progressive chronic kidney disease. Chronic heart failure is likely to result in persistently reduced renal perfusion, coupled with chronic renal congestion, sometimes termed congestive kidney failure or congestive nephropathy. Furthermore, there are significant neurohormonal changes associated with chronic sympathetic stimulation, leading to the production of substances like epinephrine, angiotensin-aldosterone, and the release of natriuretic peptides and nitric oxide. Ironically, the very therapies used for congestive heart failure, such as diuretics and agents that block the Renin-Angiotensin-Aldosterone system, can also contribute to kidney detriment by causing drug-induced hypovolemia, hypotension, and changes in the internal kidney blood flow. In human medicine, the preservation of renal function in these patients is considered of utmost importance because the presence of renal dysfunction in heart failure patients is a strong and independent predictor of poor outcomes and mortality. Now we flip the script to examine the kidney-first scenarios, type 3 and type 4, classified as cardiovascular renal axis disorder kidney. Type 3 cardiorenal syndrome, or acute renocardiac syndrome, is defined by an acute primary worsening of kidney function that subsequently leads to acute cardiac dysfunction. Acute kidney injury can damage cardiac function via multiple pathways, including fluid overload, dangerous electrolyte disturbances, neurohormonal activation, and the release of myocardial depressant factors. These factors can potentially contribute to the development of irregular heart rhythms, inflammation of the tissue surrounding the heart, and acute heart failure. A difficult clinical conundrum arises when diagnosing acute kidney injury in patients already receiving heart failure medications, as clinicians may be forced to reduce or stop those medications to prevent further kidney injury, thereby potentially worsening the cardiovascular system. Type 4 cardiorenal syndrome, or chronic renal-cardiac syndrome, reflects a primary chronic kidney disease that contributes to secondary cardiac dysfunction. The long-term cardiac consequences of chronic kidney disease are potentially serious, including decreased systolic function, left ventricular hypertrophy, and a high output state resulting from anemia. The management of these chronic combined conditions is often less acute than the acute forms, but heart failure is still often undertreated due to persistent concerns that standard treatments might further worsen kidney function, perpetuating a destructive cycle of bidirectional damage caused by the specific pathophysiology and pharmacological treatments for both conditions. Finally, type 5 cardiorenal syndrome, or secondary cardiorenal syndrome, addresses situations where cardiac and kidney dysfunction occur secondary to an independent acute or chronic systemic condition, referred to as cardiovascular renal axis disorder other. Sepsis is the most common acute condition affecting both organs simultaneously. Chronic systemic diseases in dogs, such as pancreatitis and an endocrine disorder known as hyperadrenocorticism, are classical examples that similarly affect both the urinary and cardiovascular systems. To accurately describe the clinical picture of any patient with cardiorenal syndrome, it is essential to stage the severity of both the heart disease and the kidney disease independently. For kidney involvement, the International Renal Interest Society classifications for acute kidney injury grading and chronic kidney disease staging are widely accepted to categorize acute and chronic disease, respectively. The International Renal Interest Society systems encompass a continuum of functional and parenchymal damage, and for chronic kidney disease, they importantly incorporate systemic arterial blood pressure, a critical element in the pathophysiology of the cardiorenal syndrome. However, these established staging schemes, along with conventional clinical assessments, are often too insensitive to predict the early onset of those destructive cardiorenal interactions that could greatly influence therapeutic interventions and improve clinical outcomes. This gap leads us directly to the future of diagnostics. The search for new tools has led researchers to hypothesize that novel cardiac-specific and kidney-specific biomarkers have the potential to identify the simultaneous development of cardiac and kidney injury and dysfunction in a much more timely manner than conventional clinical assessments. The hope is that these novel kidney biomarkers, in particular, will facilitate specific therapeutic targeting and disease surveillance, ultimately minimizing the establishment of the cardiorenal syndromes. Historically, worsening renal function has been inferred primarily from measurements of serum creatinine or calculated estimates of the glomerular filtration rate. However, traditional markers like serum creatinine and blood urea nitrogen can fail to detect underlying active injury imposed by cardiac disease or its management if the injury is masked by renal reserve, reduced generation rate of the marker due to progressive muscle loss, or compensatory adaptation by the remaining kidney mass. Injury only becomes evident once active damage outpaces repair and compensation. The ideal marker of kidney dysfunction secondary to cardiac disease would be a sensitive and specific indicator of renal injury, disease severity, illness, and mortality. It should detect changes in kidney impairment and function and, importantly, allow for the guidance of therapy. Although a single perfect biomarker is unlikely to distinguish all processes associated with the induction and repair of kidney injury, a panel of biomarkers predicting different phases of induction, maintenance, and repair of active kidney injury is a more realistic goal. Current blood markers used to evaluate glomerular filtration include blood urea nitrogen, creatinine, cystatin C, and symmetric dimethylarginine. For evaluating glomerular damage, proteinuria remains a vital tool, and for assessing tubular injury, markers like urinary neutrophil gelatinase-associated lipocalin have shown promising results in dogs. When considering the cardiac side, the most commonly used biomarkers are N-terminal proB-type natriuretic peptide and cardiac troponin I. N-terminal proB-type natriuretic peptide is released by the myocardium and helps regulate plasma volume, revealing congestion at the cellular level by reflecting ventricular wall stress. Cardiac troponin I is a well-established indicator of cardiac disease or injury. A key diagnostic challenge, however, is that both N-terminal proB-type natriuretic peptide and cardiac troponin I are partially excreted by the kidneys. Therefore, their measured values depend on kidney function, a fact that must always be considered when evaluating patients with concurrent cardiac and kidney dysfunction. This complex interdependency highlights why the combined interpretation of these biomarkers, set within the context of the specific clinical condition, is crucial for guiding effective therapy. The recognition of the onset or progressive worsening of kidney function in the presence of cardiovascular disease is a major setback to a successful outcome. Early recognition, facilitated by these new biomarkers, could offer greater opportunities to tailor interventions for both the cardiac and renal components, aiming for mutual benefit. Leading the charge in identifying kidney involvement are the novel active kidney injury biomarkers. These markers expose ongoing or progressive kidney injury secondary to cardiac dysfunction much earlier than conventional diagnostic methods. When measurable increases in serum creatinine or symmetric dimethylarginine are detected, the compromise to kidney function is typically substantial and the change relatively slow to develop. In contrast, novel biomarkers signal early, specific, and sensitive development of kidney injury subsequent to prevailing heart disease. Several promising candidates are being evaluated and validated in animals. These often include urinary proteins that reflect functions or cellular processes specific to the kidney that are disrupted by pathological events like ischemia, injury, or cellular stress. The most actively pursued include retinol-binding protein, cystatin C, cystatin B, kidney injury molecule 1, neutrophil gelatinase-associated lipocalin, interleukin 18, liver-type fatty acid-binding protein, tissue inhibitor metalloproteinase 2, and insulin-like growth factor-binding protein 7. Researchers are prospectively evaluating urinary clusterin, serum and urinary cystatin B, serum inosine, and urinary neutrophil gelatinase-associated lipocalin as promising early predictors of kidney involvement in various heart diseases. These markers hold attractive potential for their specific origins in renal tubular epithelia, their integral association with cellular stress or damage pathways, and their high specificity in analytical evaluation. Because they reflect active and ongoing injury in the kidney before detection by traditional diagnostics of kidney function, they offer the potential sensitivity and specificity to better forecast comorbid kidney involvement in cardiac dysfunction. One of the most intensely studied novel markers is neutrophil gelatinase-associated lipocalin. This 24-kilodalton protein is normally found bound to gelatinase in specific granules of neutrophils, but its expression is significantly upregulated, more than tenfold, in renal tubular epithelia within the first few hours following ischemic, obstructive, and toxic kidney injuries. Studies have shown that these active kidney injury biomarkers can predict impending cardiorenal events. For example, researchers observed a dog with right heart failure and abdominal fluid promoting congestive kidney failure. Following therapeutic removal of the abdominal fluid, which relieved the pressure, there was a rapid reduction in the existing kidney stress and injury, evidenced by a sharp decline in urinary clusterin and an increase in serum inosine within 2 days. Significantly, at this stage of disease, serum creatinine failed entirely to predict kidney involvement, and symmetric dimethylarginine was only slightly above the reference threshold. These findings support the hypothesis that heart failure causes active kidney injury, and if that injury is corrected by relieving congestion in this case, the active cardiac-induced kidney injury can resolve and kidney function can stabilize. Furthermore, researchers evaluated the role of serum neutrophil gelatinase-associated lipocalin in dogs with heart failure caused by degenerative valvular disease. They found that serum neutrophil gelatinase-associated lipocalin concentrations at the time of admission were significantly higher in the dogs that would subsequently develop renal azotemia within 7 days, compared to dogs that remained only in the heart failure group. In fact, the average on-admission creatinine concentrations in dogs that would subsequently develop cardiorenal syndrome were not significantly different from those in dogs without the syndrome. This evidence underscores the power of novel biomarkers like neutrophil gelatinase-associated lipocalin, which can detect tubular injury, a process that precedes the loss of renal function and the rise of creatinine by several days. One analysis determined that an admission serum neutrophil gelatinase-associated lipocalin value of 16.0 nanograms per milliliter or higher provided an optimal cutoff value for predicting the development of cardiorenal syndrome, boasting a high sensitivity of 90.9% and a specificity of 90.0%. This capability is highly superior to cardiac biomarkers like troponin I, which performed worse for predicting cardiorenal syndrome development, reflecting the fact that cardiac troponin I is a cardiac-specific biomarker, while neutrophil gelatinase-associated lipocalin is a tubular injury marker. Beyond biomarkers, advanced imaging plays a foundational role in assessing cardiorenal axis disorders. Techniques like thoracic radiography are recommended to assess the presence or absence of congestive heart failure, while echocardiography is crucial for assessing cardiac morphology, lesions, and estimating relevant hemodynamic parameters. Similarly, renal imaging is strongly recommended to improve diagnosis, prognosis, and guide potential therapies. Conventional abdominal radiographs and ultrasound help detect morphological abnormalities and determine underlying causes of kidney disease. A powerful imaging tool gaining recognition is Doppler ultrasonography, specifically measuring the renal resistive index. The renal resistive index is correlated with glomerular injury and tubulointerstitial lesions, which are common kidney diseases in dogs and cats. This measurement, derived from the flow spectrum in the arcuate artery, offers a non-invasive and reasonably inexpensive diagnostic option. One study sought to determine if the renal resistive index could serve as a useful, non-invasive marker for detecting the early stages of kidney injury in dogs with chronic heart failure due to Myxomatous Mitral Valve Disease. The researchers in that study found that the renal resistive index in the dogs suffering from heart disease, classified as stage C chronic heart failure, was statistically higher compared to healthy control dogs. This increase suggests early renal damage is occurring. They established age-dependent cutoff points for the renal resistive index. In dogs with chronic heart failure younger than 8 years old, a value of 0.775 or greater was indicative of the condition, while in dogs 8 years and older, the threshold was 0.64 or greater. The study highlighted that the renal resistive index appeared to be more sensitive in revealing kidney injury in younger chronic heart failure dogs than traditional indicators like creatinine and the newer markers, symmetric dimethylarginine and cystatin C. Surprisingly, there was no correlation found between the renal resistive index and serum symmetric dimethylarginine, or cystatin C levels. This discrepancy was noted as unexpected given the index's reported efficacy as a predictor of cardiorenal outcomes. This research supports the idea that renal resistive index may be a valuable tool for evaluating very early renal damage, possibly even before azotemia, in dogs with heart failure, specifically chronic heart failure due to Myxomatous Mitral Valve Disease. Crucially, the understanding of pathophysiology informs the management of cardiorenal syndrome. The primary physiological consequence in heart disease patients is that the kidney's blood flow is significantly compromised, which is considered the main contributor to secondary kidney disease. A low cardiac output stage activates the neurohormonal system through the sympathetic nervous system and the Renin-Angiotensin-Aldosterone system. Initially, this compensates by preserving the glomerular filtration rate, but often at the expense of active and ongoing subclinical kidney stress that eventually promotes the loss of kidney mass and function. These systems also lead to water and sodium retention, resulting in elevated central venous pressure and organ congestion. Kidney congestion further exacerbates the problem by stimulating the sympathetic nervous system and the Renin-Angiotensin-Aldosterone system, likely increasing pressure within the renal tissue and leading to progressive reductions in glomerular filtration rate, tubular fluid flow, and the induction of active kidney injury. The clinical implications of congestion were powerfully demonstrated in a small study that focused on dogs with abdominal fluid due to right heart failure. This study showed that an acute decrease in the pressure inside the abdomen following therapeutic fluid removal led to a favorable increase in serum inosine, a biomarker reflecting relief of kidney injury or stress, within 24 to 48 hours. These dramatic improvements, occurring without changing the therapeutic protocol, strongly illustrate how rapidly the status of the disease and its management can be reflected by these specific biomarkers and reinforce the pathological importance of congestion. The management of cardiorenal syndrome patients presents a constant tightrope walk, often forcing clinicians to balance conflicting goals. For instance, a major goal in treating congestive heart failure is to reduce the volume of fluid and hydrostatic pressure, typically through the use of diuretics. Conversely, the treatment of acute kidney injury and chronic kidney disease requires maintaining adequate intravascular volume and pressure to ensure sufficient renal perfusion, often through parenteral fluids. Finding the right balance becomes extremely challenging when both organ systems are simultaneously failing. In cases of cardiovascular renal axis disorder heart unstable, such as acute congestive heart failure, the therapeutic margin is small. The use of diuretics and drugs that block the angiotensin system can have adverse effects on kidney function, and overly aggressive fluid removal that leads to excessive dehydration must be avoided. Strategies to minimize the worsening of kidney function during treatment include adjusting the dosage or frequency of diuretics, employing agents to increase cardiac output and kidney perfusion, such as pimobendan or intravenous dobutamine, and using arterial or venous dilators. The dilemma surrounding diuretic use is pervasive. Diuretics are recognized as a double-edged sword. They save lives by reducing congestion, but improper or overuse can cause harm. Excessive doses of loop diuretics can decrease renal perfusion and consequently the glomerular filtration rate, even though, conversely, reducing renal congestion may improve the glomerular filtration rate and slow the progression of chronic kidney disease. In human medicine, the appropriate reduction of congestion is associated with significantly longer survival times, even if there is a mild or moderate increase in renal function markers like serum creatinine during the therapeutic maneuver. This suggests that the worsening renal function observed in the context of treating congestion may be tolerated within limits, as the patient benefits from decongestion. Regarding the use of drugs that block the renin-angiotensin-aldosterone system, these are generally beneficial in both cardiovascular and renal diseases. However, patients with renal dysfunction are often less likely to receive them due to the concern of worsening renal function. Research has shown that these drugs, such as angiotensin-converting enzyme inhibitors and angiotensin receptor blockers, are beneficial even in patients who experience worsening renal function. Therefore, maintaining patients with cardiorenal syndrome on these drugs may be beneficial despite a mild increase in renal function markers. Additionally, mineralocorticoid receptor antagonists, often known as aldosterone blockers, have the potential for both renal and cardiac protection. The positive inotrope pimobendan improves systolic function, which may subsequently increase the glomerular filtration rate. The use of nutritional supplements, particularly omega-3 fatty acids, is recommended as an antioxidant and appetite stimulant in patients struggling with both heart and kidney disease, although their safety and efficacy are still under rigorous investigation. Finally, for all forms of cardiovascular renal axis disorder, aggressive management must include systematic monitoring of systemic arterial blood pressure, as the kidney and heart are both at high risk for damage from systemic hypertension. The goal is to maintain systolic blood pressure below 160 millimeters of mercury to minimize target organ damage. Moving beyond general management, recent specialized research offers exciting new avenues for treatment, focusing on highly targeted molecular pathways. One significant avenue of research involves a class of drugs known as angiotensin-neprilysin inhibitors, represented by a combined compound of sacubitril and valsartan, which has shown promise in canine models of cardiorenal syndrome. Researchers developed a canine model of cardiorenal syndrome characterized by chronic heart failure due to coronary microembolization, combined with compromised renal function induced by surgery. The renal dysfunction in this model was intentionally created to mimic the equivalent of sustained elevated central venous pressure, a key contributor to cardiorenal syndrome. Long-term treatment, specifically 3 months of therapy, with sacubitril and valsartan yielded significant benefits. The treatment significantly improved the left ventricular ejection fraction, which is a measure of left ventricular systolic function. This improvement in systolic function was accompanied by a significant reduction in various cardiac and kidney injury biomarkers. Plasma biomarkers of heart stress, such as N-terminal proB-type natriuretic peptide and cardiac troponin I, decreased significantly. Furthermore, biomarkers reflecting kidney injury, specifically urinary kidney injury molecule 1, urinary neutrophil gelatinase-associated lipocalin, and plasma cystatin C, also showed significant reductions following the treatment. Histologically, the treated dogs showed significant reduction in the total volume fraction of kidney fibrosis compared to the untreated control group. Crucially, the treatment improved mitochondrial function within the heart tissue itself. The maximal rate of adenosine triphosphate synthesis was increased, suggesting improved energy availability within the failing heart muscle. The drug combination also suppressed the signaling pathway for cell death, or apoptosis, evidenced by decreased levels of cytosolic cytochrome C and active caspase-3. These findings suggest that sacubitril and valsartan may prevent the ongoing loss of functional cardiac units, contributing to the long-term prevention of worsening heart failure. However, the study also revealed complexities. Although the biomarkers of kidney injury decreased, traditional kidney function measures like serum creatinine and blood urea nitrogen did not show significant improvement over the 3-month period. The researchers hypothesized that the marked reduction in injury biomarkers may signify the prevention of ongoing kidney damage, supported by the reduction in kidney fibrosis observed in the treated group. Overall, the study supports the potential of this therapeutic strategy to mitigate cardiorenal syndrome by improving heart function and decreasing biomarkers of organ injury, which may lead to longer-term preservation of renal function. Another frontier in targeted therapy involves designer natriuretic peptides, molecules engineered to act on specific receptors for organ protection. One such innovative peptide, named CRRL269, was investigated in a large animal canine model of acute kidney injury induced by ischemia and reperfusion, simulating surgical aortic repair. The ultimate rationale for developing CRRL269 is to achieve renocardiac protective actions without the adverse side effect of hypotension, which often limits the use of native peptides in acutely ill patients. The study confirmed that CRRL269 is a potent activator of the particulate guanylyl cyclase A receptor, a key pathway for renocardiac protection. In the canine model, CRRL269 successfully preserved the glomerular filtration rate and increased renal blood flow during the post-ischemia phase. It also promoted diuresis and natriuresis, Furthermore, it suppressed the highly deleterious hormone plasma angiotensin II. Critically, CRRL-269 achieved all these renal benefits while maintaining mean arterial pressure, preventing the drop in blood pressure often seen with native peptides. This maintenance of blood pressure is essential, as hypotension can compromise renal perfusion and negate the drug's therapeutic potential. The peptide also demonstrated cardiac protection by reducing cardiac filling pressures, specifically the right atrial pressure and pulmonary capillary wedge pressure. At the cellular level, CRRL-269 reduced kidney injury, as evidenced by less kidney tissue damage, and significantly reduced renal cortical apoptosis, or programmed cell death. In laboratory studies, this anti-apoptotic effect in renal tubular cells was superior to that achieved by native natriuretic peptides. The researchers believe that CRRL-269 may thus serve as a renocardiac protective agent for acute kidney injury treatment. They also explored the potential of urinary C-type natriuretic peptide as a novel biomarker for identifying acute kidney injury, finding that its levels increased markedly during the ischemia and reperfusion phase. The scope of cardiorenal involvement can even extend beyond the heart and kidneys to include the central nervous system, creating a dangerous triad known as cardiorenal cerebral syndrome. Although literature on this is sparse in veterinary medicine, a recent case report highlighted this connection in a dog. The case involved a 14-year-old miniature pinscher presented with severe bradycardia, a markedly low heart rate caused by a third-degree atrioventricular block. The patient also exhibited kidney impairment characterized by azotemia, hyperphosphatemia, and severe hyperkalemia, along with decreased urination. Within hours of hospitalization, the dog deteriorated neurologically, developing multifocal central neurological signs, including decreased mentation, vertical eye movements, quadriparesis, and ventral neck flexion. The primary diagnosis was deemed to be cardiovascular renal axis disorder heart, specifically type 1 cardiorenal syndrome, because the acute drop in cardiac output resulting from the severe bradycardia led directly to hypoperfusion of the kidneys and the brain. This hypoperfusion was the trigger for the severe hyperkalemia and acute kidney injury. Based on the understanding that the dysfunction originated primarily in the heart, the decision was made to proceed with permanent pacemaker implantation to restore a normal heart rate and improve cardiac output. The pacemaker successfully increased the dog's heart rate and cardiac output. Following the procedure, the neurological signs, specifically the neck flexion and abnormal eye movements, resolved. Within 24 hours, urine output returned to normal. The patient's kidney function markers, while still slightly abnormal, progressively improved, and the neurological status continued to normalize, leading to the dog becoming ambulatory with assistance. This case beautifully illustrates the concept of cardiorenal cerebral syndrome and, more importantly, demonstrated that the renal and cerebral injury can be reversible if the underlying primary cardiac dysfunction. In this case, the slow heart rate is corrected quickly. Improved recognition of the pathological origin in such complex systemic cases is critical because it allows for expedited, appropriate medical treatment, which leads directly to a better patient outcome. In conclusion, the complexity of cardiorenal syndrome and cardiovascular renal axis disorders underscores the need for a collaborative, multidisciplinary approach. The ability to identify and understand the intricate pathological characteristics of this syndrome is increasing, offering new potential for improved outcomes. The greater utilization of existing and emerging organ-specific biomarkers, which are proving far more sensitive than traditional diagnostics, forecasts new paradigms for the diagnostic evaluation and treatment of heart disease in our canine companions. Whether through non-invasive techniques like the renal resistive index, innovative therapeutic strategies like angiotensin-neprilysin inhibition or designer natriuretic peptides, or simply better recognition of the interconnected axes of disease, the future of managing these challenging cases looks brighter. The ultimate goal is to maintain a fine balance, ensuring adequate fluid status and renal perfusion while simultaneously managing the cardiovascular system to minimize congestion and neurohormonal activation. This requires constant, careful monitoring of conventional measures alongside the promising new diagnostic indicators. Thank you for listening. The titles for the reference papers are in the video description. From Vet Med Digest, where we keep minds inspired, hearts light, and tails wagging.